Following a terminal diagnosis, families cross what is known as the diagnosis threshold. Here, they discover a medical system engineered for transactional precision, but lacking the infrastructure for continuous human presence. This structural abandonment forces families to navigate the complex logistics of decline in a vacuum. Without specific biological and administrative defenses, the family system is left to manage the full pressure of the transition without institutional guidance. Modern medicine divides the patient into two parts. The institution manages the clinical perimeter, the objective data found in scans and therapeutics, while leaving the patient's emotional interior entirely isolated. This divide creates the presence gap. While resources are concentrated in 15-minute appointments, 92% of critical decisions actually happen in the unguided spaces between visits. In this gap, 53 million Americans are forced to provide 36 billion hours of unpaid, unguided care annually. This lack of coordination drives $900 billion in systemic waste and turns disease progression into a cycle of reactive crises. Without continuous advocacy, families default to an optimism bias. Patients and clinicians often enter a collusion of denial, focusing exclusively on aggressive downstream treatments to avoid the reality of mortality. That denial eventually shatters. When physiological decline makes the truth undeniable, families suffer the existential slap. This sudden realization triggers a highly contagious panic that can rapidly destabilize the entire family unit. The clinical cost of this panic is measurable. When surrogates overestimate survival odds, it correlates directly to a 56% longer duration of aggressive, unwanted ICU treatments before death. The subsequent administrative avalanche is equally damaging. Lack of preparation subjects the estate to a public probate process that freezes assets for up to 24 months, while immediate digital lockout can strip families of access to critical financial accounts. Navigating the diagnosis threshold without proactive management compromises both a family's financial security and their long-term psychological stability. You cannot logic a family out of an autonomic panic crisis. To stop the spread of anxiety, families require a sovereign guardian, an advocate who can act as a physiological firewall between the system and the family. This intervention is rooted in polyvagal theory. 80% of vagus nerve signals travel from the body upward to the brain. Because panic takes the brain's cognitive centers offline, this body-to-brain pathway is the only way to restore executive function. The guardian acts as a biological vagal anchor. By modulating tone, breathing, and the physical environment, they send safety signals up that 80% pathway. This manually applies the vagal brake, forcing the sympathetic nervous system to stand down. With cognitive logic restored, the guardian helps the family implement a legacy and contingency packet well before the existential slap occurs. This upstream logistical shielding bypasses the probate freeze and digital lockout, ensuring the family maintains operational control of their own transition. The diagnosis threshold forces a choice between two outcomes: succumbing to a reactive clinical crisis or maintaining sovereign, structured agency. Non-clinical advocacy acts as a structural bridge, filling the presence gap that the transactional medical system is design-constrained to ignore. Integrating presence layer protocols into outpatient care moves the existential slap out of the realm of emergency, replacing unmanaged crisis with coordinated agency.